In the continuation of infectious medicine, today our topic is around the typhoid fever. So typhoid and paratyphoid fever, it is caused by salmonella typhi and salmonella paratyphi. So it is caused by salmonella typhi and salmonella paratyphi. While salmonella typhi, it is most common. It results with systemic illness with fever and abdominal pain. Now, how the typhoid fever is transmitted? So let's talk about the mode of transmission. So typhoid fever, it is transmitted by feco-oral route. It is transmitted by feco-oral route. It is transmitted by contaminated foods. And it is transmitted by direct person to person. So the typhoid fever, it is transmitted by feco-oral route. It is transmitted by contaminated foods with a fecal containing salmonella typhi, and it is transmitted by direct person to person, like by handshaking. So let's talk about the pathogenesis of typhoid fever. How typhoid fever it causes the disease. So whenever person ingest food, so what happens? Whenever person ingest foods containing salmonella typhi, so the bacteria, it travel up to the distal ileum. It travel up to distal ileum. Once salmonella reach to distal ileum, so it resides in PR patches. What happens? It resides in PR patches. Then it proliferate in which cells of the PR patches and M cells of PR patches. So first it reside in PR patches, then it proliferate in the M cell of PR patches, and it reach to the bloodstream. And that is called as septicemia or sepsis. So I repeat, whenever person ingests food containing salmonella typhi, and remember the point that the larger number of organism is required to cause infection, like almost 10 raised to power 5 organism it required. It means such a larger number of organism is required to cause infection. So when the person ingests food containing salmonella typhi, it reaches distal ileum, and distal ileum, it resides in PR patches, then it proliferate in the M cells of the PR patches, then it reaches to the bloodstream. Now once it comes into bloodstream, then from bloodstream it can travel to liver, spleen and gallbladder. So from the bloodstream it can reach to the spleen, liver and gallbladder. So it means that typhoid is not the illness which is confined to GIT only, rather it is distributed throughout the body. In order to understand there are three phases. So there are three phases according to the week of onset of symptoms. It means that first week constitute as first phase, second week constitute as second phase, and third week it constitute as third phase. So now let's discuss the first week. What are the clinical features in first week? First of all, you should know that what is the incubation period of typhoid fever. The incubation period of typhoid fever, that is from 5 to 30 days. What does it mean? It means that when person is infected with typhoid fever, so up to 30 days there will be no symptoms, but after 30 days the symptoms begin to develop. So in first week the patient will come to you and there will be main complaint of gradual increase in fever. There will be a gradual increase in fever. Along with that, there is relative bradycardia. Along with that, there is relative bradycardia. Now, always keep in mind, so whenever there is fever, so it is always associated with increased pulses, meaning fever is associated with tachycardia. But in case of typhoid, the fever is associated with bradycardia. So it's important. So the other point is there might be diarrhea and or constipation, and they are almost an equal frequency, and there might be headache. So these are the first week symptoms. Now what is the clinical features in the second week? So in the second week, there is main important is continuous fever. So there is continuous fever, and this continuous fever, it is also called as step ladder fever. Why it is called as step ladder fever? The reason is that the fever is increasing with the passage of time. I mean to say, this patient will give you history that I have no fever in early morning, but in late evening they had a fever. So in step ladder fever mean that in early morning there will be no fever, but in late evening the fever will be increases. So this is continuous fever, and there are rose color spots. There are rose color spots, and they are mainly, these rashes are mainly present around the umbilicus, and it is present in the lower abdominal area. And there is coated tongue. Coated tongue. So the white coated tongue, they are also in the second week. Now there might be delirium or coma. There might be delirium or coma. A salmonella can penetrate into the brain. So these are the in the second weeks. Now what are the clinical features in the third week? In the third week, these patients have similar clinical features just like the second week. So in third week, all the clinical features, they are just like the second week, but there are certain complications are there in third week. These complications could be GI ulceration, there might be PR patches, perforation, and there might be hepatosplenomegaly. So in third week the features are just like second week, plus there are some complications in the form of GI ulceration, PR patches, perforation, and hepatosplenomegaly. But in rare case, it is found that this patient could suffer from meningitis, they might be suffer from myocarditis and renal failure. What are the investigations? So for the typhoid fever, the gold standard is culture. Culture is gold standard. Now for this you have to know the mnemonic, that is BASO. So for the every week we have to do different culture. The first week we have to do blood culture, and the second week we have to do antibody test in the form of Vidal test or typhoid test. And third week we have to do stool culture, and fourth week we have to do and fourth week we have to do urine culture. So in the first week there is blood culture, in second week antibody test, and third week stool culture, and fourth week there is urine culture. For the treatment, in case of treatment, there are two approaches. So if typhoid is not resistant to quinolone, and if typhoid is resistant to quinolones. So in order to treat the typhoid fever, we have two approaches. If the typhoid is not resistant to quinolones, so what we need to do in that case, so we have to give quinolones. Simply, if typhoid is not resistant to quinolone, we have to give quinolones. So in the quinolones, we have two options: first line drug and second line drug. So we have first line drugs and we have second line drugs. In the first line, we have tablet ciprofloxacin 500 mg per orally and to 10 days, right? And for in the first line drug, we have tablet cipro 500 mg per orally and to 10 days, or we can give cipro in IV in the dose of 400 mg and to IV and to 10 days. In second line drugs, the option is tablet ofloxacin 400 mg per orally BD and to 10 days, right? And the second line drugs are tablet ofloxacin 400 mg per orally BD and 10 days, or we can give tablet cefixime. Cefixime are the third generation cephalosporin, and the dose is 200 mg per orally BD and 10 to 14 days. We have to give tablet azithro, and the dose is 10 mg per kg per day, and we can increase the dose up to 1000 mg. The treatment option in severe typhoid. So in severe typhoid, there are two approaches: whether without CNS impairment and with CNS impairment. It means if there is severe typhoid and the patient is manifested without CNS impairment, so in that condition we have to give injection ceftriaxone. Injection ceftriaxone 2 gram IV BD 10 days. 10 days, 10 to 14 days, right? Or we can give injection cefotaxime. We can give injection cefotaxime 2 gram IV BD into 10 to 14 days, right? If the patient is manifested without the CNS impairment and there is severe typhoid. There is severe typhoid and that is manifested with CNS impairment, so in that condition we have to give injection DEXA. Extensive drug resistant strain. Now there are some strain of typhoid which is resistant to quinolones, but at the same time they are resistant to third generation cephalosporin. So in that condition, what are the options in order to treat the patient? Now the options in case of extensive drug resistant strain, for that we have to give meropenem. Dose is 1 to 2 gram IV every 8 hourly for 10 to 14 days. So in extensive drug resistant strain, we have to give meropenem 1 to 2 gram IV every 8 hourly in patient for 10 to 14 days. The most important point regarding extensive drug resistant strain is that in where this strain is actually more common. So worldwide, this extensive drug resistance, unfortunately, it is more common in Pakistan. So it is important. Now, if the patient is also presented with ileal perforation, so in that condition, what you can do, you can give broad spectrum antibiotic. Now in the prevention, in case of typhoid, the most important is vaccination. Vaccination plus water and food safety. So not only vaccination is important, but along with vaccination, the water and food safety, it is important. Now this vaccination, it is available in the form of live attenuated vaccine and inactivated vaccine. Now, live attenuated vaccine, it is given 48 hourly and 10 days before travel. While in another hand, if we talk about inactivated vaccine, these are polysaccharide capsule of salmonella. 1 IM injection, it is given 10 days before traveling in endemic area. Vaccine, it is given after 2 years. Please keep in mind that this live attenuated vaccine and inactivated vaccine, it doesn't give lifelong immunity, and that's the reason that in case of typhoid, the vaccination is not only important, but along vaccination, the water and food safety is also important. So students, that's all about the typhoid fever.